Okay, then, I'm Tanja. I'm based at the University of Bristol, and as Michelle just mentioned, I'm the statistician and data manager for the cohort study, and that's a role I've had for the last 3.5 years now. It's quite an exciting job as I get to be involved in lots of very different and diverse research projects having to do with the cohort. And today I'm mainly going to talk about building a prognostic index for Parkinson's and a little bit about cognition as well. And this prognostic index for Parkinson's is one of the major results that we'll get out of the cohort study and especially out of the extension that we're currently on. So this in the top here is a quote from the grant proposal, which says we'll develop a prognostic index detailing the longer-term trajectory of Parkinson's that can be modeled on an individual basis following diagnosis. So what does that really mean? That means we want to determine, seeing patients at diagnosis or shortly after diagnosis, who is more at risk of certain outcomes, for example, freezing of gait, experiencing falls, dyskinesias, developing cognitive problems. Why do we want that? Well, on the one hand, a lot of people with Parkinson's who've been diagnosed ask these kind of questions and do want to know. Of course, it's not information that should be forced upon anyone, but a lot of people have these questions. So we want to have the best information to give to people. Then, of course, for clinicians, it's timely counseling and targeted intervention. So if you know who's at higher risk of developing a certain problem, you'll know better what to do. And then finally, of course, optimal recruitment into clinical trials, because if you want to study if an intervention works for a particular outcome, the best group to study that in is those with a high risk of that particular problem. Very brief detour away from Parkinson's. So prognostic indices and prognostic modeling is something that's all over healthcare, not just particular to Parkinson's disease. And one very popular tool and well-known one is the QRisk, or now QRisk-3, which is a prognostic model or prognostic index for the risk of heart attack or stroke within the next 10 years. And this is something that's freely available online to anyone who wants to use it. And the data you need to put in is something that pretty much everyone knows about themselves. So simple things like age and sex, smoking, diabetes or so. And if you have also certain clinical parameters like blood pressure or so, but fairly simple. And then what it will give you is a risk of developing or having a heart attack or stroke within the next 10 years, and it illustrates that with this little square of smiley faces. And the more happy faces, the lower your risk, obviously. And then another example, a very different one, just to show how diverse these kind of prognostic models in healthcare can be, is from the COVID-19 pandemic, where, of course, in a very short period of time, lots of research emerged. And this is a study that looked at predicting who of the patients in hospital with COVID-19 might develop a particular severe form and might need to be transferred to intensive care units. And it's a very different model in that this is something that only a clinician will be able to use, and uses things like respiratory rate or particular blood tests and all that. So that's on the other end of the spectrum, like specific for a clinical application. So back to Parkinson's. I was quite lucky in preparing this talk in that there was a systematic review of prognostic models in Parkinson's published earlier this year. So systematic review simply means that a group of researchers decides to take the time to search the databases, go through all the literature, and summarize what we have on a particular topic so far, to then also make some suggestions what needs to be done next and where a field needs to go. So they have done this for prognostic models in Parkinson's. And so they covered all the research until 2021. And they've identified, I think, 25 studies that develop prognostic models for a particular aspect of Parkinson's disease. And some of these studies, of course, cover more than one particular outcome, so even more models than just studies looking at this. The outcomes most studied were so far falls. So there were 13 models that predicted the risk of falls of patients. And the second most studied is cognitive problems, either cognitive impairment or dementia. So given that there are all these models out there already, why do we still want to work on this and put a lot of time and effort into it? Well, these models, it's great that we have these models, but also most of these models made short-term predictions only, so predicted 2 years or even less ahead, which can be very helpful still if you're thinking about targeted interventions. But if you're thinking about being a newly diagnosed patient, you also want to know what happens in 5 years, what happens in 10 years. The next 2 years is just not enough. And then about half of the models were not externally validated. That means they didn't test it on a completely independent data set that has not been used when developing the model. So to be able to know that you can really use such a model and that you can use it for people with slightly different characteristics or other populations as well, it needs to be externally validated. And then finally, most studies were performed in Europe, US, or Australia, so non-Caucasian populations are underrepresented. And while I guess if you take a look around, the last point is not necessarily one we can tackle, but the first one two definitely are. So we've got an independent data set from the Tracking Parkinson's cohort, which is UK-based as well, but completely independent. And so we can do this external validation. And as you know, we've been following you up for 15 years now, I believe. So we definitely can also make predictions ahead far further than just those 2 years. So next I want to touch upon 2 projects that we've completed already that feed into this prognostic index that we're going to focus on over the next couple of months. So one, I think I presented on this at the Open Day 2 years ago when it was work in progress. So this is now published. And for this, we not only used the data from the discovery cohort, but we combined it with the Tracking Parkinson's cohort and the PPMI cohort data as well, so that we had in total over 3,000 patients. And we started with just looking at some very simple summary statistics. So we just looked at how common motor complications, dyskinesias, and motor fluctuations or off states are across the course of the disease. And the main lessons learned from these, like just on a general cohort level, were that motor fluctuations are more common than dyskinesias. You can compare the colored bars in this and this figure. And then probably even way more importantly, that motor fluctuations were at clearly of greater impact to patients than dyskinesias, which you can see by the bigger and darker shaded bars at the bottom figure there. So this was at the group level, and then you start, of course, wondering who is at higher risk, who has a higher probability of developing these problems, and who hasn't. And one simple thing was, of course, splitting it by sex. And we found that both dyskinesias and motor fluctuations are a bit more common among females, or a bit more commonly reported by female Parkinson's patients. And then I think in terms of towards the prognostic index, this is probably the most interesting one, because we didn't just look at this only by sex, but also by age group, medications, and so on. And if you put all these factors together, and then you compare those people which, according to our analysis, were at highest risk, so this is the 20% with the highest risk, and this is the 20% with the lowest risks, you see there are quite big differences. So that means what an individual is like, it's very individual parameters, age, gender, medication or so, really do have an impact on how common certain outcomes are. The second project I want to touch upon is a more recent one on cognition in Parkinson's. Here we've basically wanted to know how good a very short and simple test of cognition is compared to a more elaborate gold standard cognitive testing, which is great to have, but also very time consuming. So we used data from the PPMI cohort for this, because they collect both this very simple, the mocha test that you guess all know and have done, and more elaborate cognitive testing. And we asked from the quick assessment, from the mocha, how well can we predict the outcomes of the more elaborate cognitive testing, and how well can we predict what diagnosis a clinician would make when he sees you in clinic. And we did this because then eventually our findings will allow us to use the data that we've collected from you, this relatively simple cognitive testing data, best as possible in developing prognostic models for cognitive problems. So these are two images from the article, and this is something used quite often. These are so-called ROC curves. And here at the top corner you see a little explanation of how to understand or how to interpret these. So basically when you've got an AUC of 1, so you've covered all this area here, the curve is up here, that would mean your test is perfect. So this is something that in reality you never get for anything. And this is the other end of the spectrum. So if the curve is here and you've just covered like this triangle here, that means your test is as good as a random guess, so useless. So you want to be as far up here as possible. And that's what we found with this mocha test. So this is generally considered very good. Of course, it always depends on the application and what you want to know, what's good enough for you. But the interesting thing, I think, to see is that for very mild cognitive problems, the mocha doesn't work quite as well, but for more pronounced cognitive problems in more elaborate testing, so when more than one domain is affected in this higher order testing, this mocha test works quite well in identifying this. And same if we do this to predict diagnosis from the clinician who does the patient visit, and also talks to the patient, discusses with the patient, so he has she has both the cognitive testing data and the general impression, and still the mocha test does fairly well. So yes, finally to end my talk, a little bit about what I'm going to do over the next couple of months and how we're going to put the different puzzle pieces together to get a prognostic index for Parkinson's from all the data we've collected from you. I think I've touched upon most of these aspects already. Of course, we need to decide on what to predict. And some of this is already in our grant proposal, so we definitely will look at important motor outcomes like experiencing falls, problems with dyskinesias and things like that, and also cognitive problems. The interesting thing is that, of course, we want to consider the priorities of you, the priorities of the clinicians, the priorities in research, and there's always some overlap, but there's also differences, and everyone has a slightly different angle to what's of interest. And there was a quite interesting recent paper that looked at outcome measures for trials and the most important things from the people with Parkinson's perspective. And an interesting thing for me to see in there is that it also changes. So it, less than 5 years from diagnosis, it might be different things than later on. And also it seems to be a bit more of a mixed bag early on. Like everyone has their very own priorities. And later on, there are certain things that seem to be of general concern to people, like especially falls or problems with swallowing. Then I've tried to show that a little bit with the detour outside of Parkinson's. There's also the question of what to include in a model. Of course, you want to have something as accurate as possible, but you also want something simple that's practical and can be applied by a clinician or even used by a patient themselves. Then I'm a statistician. There's also some statistical challenges in there. An important one being informative censoring. That means, well, of course, we've got data from lots of you until 10 years or 12 years after diagnosis. We don't have this data from everyone. And unfortunately, of course, those people with more severe disease, especially those with cognitive problems, are more likely to withdraw from studies. So that's what statisticians call informative censoring. And then there's the issue of the problem of updating. So, of course, we know certain things at diagnosis and can measure certain things, but as you observe someone longer and you see how their Parkinson's develop, you get more information, you understand that person better, you know more, so you can make also better predictions what might happen in the next years. And then finally, one that I'm quite interested in is how to report what we found, because visualization of these kind of things is also quite important, as with every model there's uncertainty which needs to be communicated and openly shown so that people can interpret what they see in the best way possible. And there's also the question of absolute versus relative risk. So of course, if you think of the Q risk I showed you in the beginning, it gives you an absolute risk of that many % of developing something within a particular time frame. But you could also think of relative risk. For example, you might want to know how likely am I going to experience falls compared to someone my age without Parkinson's? Or you might wonder, how likely are you to experience falls compared to an average person with Parkinson's? It all gives you kind of the same information, but from a very different angle. And like understanding these things, I guess, works best if you've got all the angles together. And yeah, there's also lots of work and research on how to visualize these risks and uncertainties so that they are understandable to clinicians, researchers, and people with Parkinson's. And then finally, this is a fairly recent summary of how much visits have now happened in the discovery cohort. And this is just to show that we've got like really lots of data, wells of data to use and put into developing such a prognostic index. And with that, a big thank you to all the study participants, first of all, of course, the study team, and Parkinson's UK. And yeah, all these things would be really great to also iterate and discuss with some of you over the coming year for sure, because I think we can learn a lot from your perspectives as well. Thanks.